Hey there, my DPC Story listeners. I'd like to let you know that this episode contains some sensitive language. If you have little ones nearby, please use discretion. Direct primary care is an innovative alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever so relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Maryal Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care. This is incredible how fast the last year has passed. We are already celebrating year 5 of the practices that we are highlighting today. And if you are new to the podcast, please start by listening to the first 10 episodes of the podcast, where you can hear the nidus of all of these physicians. We've been so fortunate to have them share their stories at year 1, year 2, year 3, year 4 anniversaries, and now year 5. So welcome back to the podcast, everybody.
Hi.
Thanks so much. Glad to be here.
Oh, thank you.
Yay! And if you want to see their amazing faces, go to YouTube for sure. But, I was just listening to, as I traditionally do before we do our annual recording, I was listening to your guys' updates from last year. And DPC has changed for all of your lives in terms of one more year under your belt, but also this country has changed in the past year. So we're going to be talking about that. So I would love if we could start with updates as to what's been happening. So let's start with Defiant DPC. Dr. Jake and Dr. Christina Mutch are here today, and they're going to be talking about what's been happening at Defiant.
Yeah, so super exciting over the past year. One of the things that kind of just happened, again, by happenstance, is we ended up hiring a 4th doctor up to the practice. So it's the 2 of us plus Dr. Eileen and now Dr. Derek. And that has been wonderful. That was earlier this year. And so we've just been kind of getting all of the protocols that we had set up when we were hiring Dr. Eileen, because that was a kind of a huge undertaking to figure out. We kind of use that same sort of launch pad and those like that to-do list to help make it a little bit easier for the next time. And now we're fine-tuning that because we're kind of getting musings from other doctors who have reached out thinking about something similar. So very excited about that. We also just recently, a couple of weeks ago, we hired a nutritionist slash wellness coach as what we're kind of putting as a wellness guide, so to speak, to help bring our vision for what primary care is. So longevity forward doctors, unparalleled care coordination, but then also having a wellness professional to help guide people who really want hand-in-hand service. And so we'll have a wellness membership. We've just bought a bioimpedance scanner as well. And so we're going to be doing some more detailed measurements for the people who want that really high touch specific tracking. So very great stuff. We've expanded our operations team as well. And so we're kind of getting the crew bigger and just trying to make sure that we're all staying focused on trying to deliver what we see as elevated primary care. So super excited. Lots of stuff happening. It feels like it's all been happening very, very quickly, but we're excited.
I would say the only thing I have to add is that we've expanded our community outreach a bit. So we started Walk with the Doc now. Oh my God, 2 years. I think we celebrated our 2-year anniversary this year. And we've expanded that to kind of doc talks around town to different fitness studios to kind of, again, in a day and age with so much misinformation and resource overload, kind of just taking it back to grassroots and being available in the community. And those have been really well received. And I can tell that the people there really have appreciated it. And they're just on basic prevention topics, but they just don't get that time with their doctors, and they may not be a patient of ours. So it's like giving them that time to ask questions and dive deep on some preventative topics has been really fun. And then we've also expanded our Sweat with the Doc series, which is basically where we take our patients and make partnerships with different fitness studios to try different exercises together, and just kind of, again, trying to get everybody to find their exercise home. And it can be really intimidating. So we get to look silly with them, I tell them. And so we're doing Tai Chi this weekend. I've never done that before. We've done Pure Barre, we did Orange Theory, we did yoga. I feel like I'm missing one, but yeah, it's been really fun and the patients have really loved it. So it's just been a fun way to kind of, I think we're trying to find ways to build community outside of the office.
Yeah. Oh, and Christina got menopause certified as well too, which is awesome. And so we have a lot of patients asking about that. And so it's nice to be able to kind of pull those resources together and talk about challenging cases or the best way to move forward with stuff. Absolutely love it.
Pause before certified. I thought you were just like, Christina got menopause.
I know. I'm like, how do you say
It's
that?
contagious because the
I don't think
vaccine.
that's your
The
story
vaccine.
to share, Jake.
No, you're not dealing with the top
Hopefully that-
brass when you're talking to me, that's for sure.
Oh my God.
my God.
I was like,
Sorry, Christina.
Not yet. I'm sure.
Certified.
Happy wife, happy life. That's hilarious.
Not today.
So we're dipping our toes in, and I have so many questions to follow up with what you guys have already mentioned, but let's turn it over to Dr. Lauren Hughes at Bloom Pediatrics and Lactation. I would love to hear your update as to the things that have happened in year 5 for you.
so my third doctor is starting on Monday, which is just wild. Still have no staff, still holding strong with no staff. And it's been really fun. My social media has gotten, I kind of like this platform now, and I get to like talk and I get to educate, and it's opened very unexpected doors. Anytime I talk about DPC, or I'm like, hey, guess how much an x-ray is? $30 without insurance. And I do that anytime people are like, excuse me, I have good insurance and it costs me 3 times that much. I'm like, well, good insurance is an oxymoron. So, and so there's a lot of just like education about people not knowing that they could ask for a cash price at specialties or and for imaging or for labs, not knowing that that is an option. Giving examples of this is how DPC saved this patient money. A lot of education around like other direct care clinics and like how to become what we are is a Medicaid ordering, preferring, prescribing provider. So like we can see Medicaid patients, Medicaid recognizes our orders, we just don't bill Medicaid. So there was a lot of, well, what about those kids? And it's no, we actually have a gap coverage for that. And so that has been really good. Every year I do a community fall vaccine clinic because people are really scared of vaccinating kids. And so that has been interesting to figure out this year. And so it's been really helpful that I was able to talk with like my Pfizer rep, with my VaxCare rep, with all of these different people on how access is going to look. And luckily for us this year, access is looking equivocal to previous years. I just have to click one more button. Fine. And so that's something I always do, which I think is really important for people to understand, like the importance of vaccination, the importance of like herd immunity protection, that sort of thing, but also just as a like free way to provide that to kids and get more kids in the community protected. And like kind of going along with the vaccines is that I can't even count the number of messages of people that are like, thank you for continuing to talk about this and continuing to debunk. I can't, dozens of messages of we were scared to vaccinate, now we are. And that's been really wonderful. I even had someone from, where was it? They're stationed in the UK and was just it got me. She said, just thank you so much for sharing your knowledge. Your work matters and has made a positive impact on my family's life. And just like that sort of thing of me yelling at my phone is making a positive impact across the world. What? It's wild. And so it's not even like just my own community now. And that's so cool. It's so cool.
It's so cool. And I think it goes back to even when you opened your practice, all of you probably couldn't have seen this coming. Nobody could have seen what has happened in the past few months happening. But what I will say is that it really builds on why you guys started practicing and the doctors that you were before opening and the doctors you are now. So Dr. Mundkur, I would love to hear about what's happening at My Happy Doctor, because one of the things too that you were part of this year that wasn't in existence prior was you were part of the California DPC Summit.
Yes, I was going to mention that.
Set of speakers. Yeah. And so community, I've definitely boots on the ground wise have seen the impact that you've made in California, but I'd love to hear what's been going on with your practice and your community.
Yes. So I think I took your advice from Jake about raising his prices and actually seeing a great outcome. And I did it and it worked great. I feel like I went from being a cheap doctor to a rare disease expert. It's just incredible how your time is valued and money kind of defines how your practice might be. It made a huge difference. And I'm so thankful for these get togethers we have every year because it teaches me so much. Even though it's not, we're so different in many ways and how we practice and like how we grow our practices. I just feel like there's the common theme of community well-being, really being like providing personal care, personalized care to each patient and valuing each patient as a person and not like a number that they usually experience in the healthcare system that we have right now with the insurance model. So one is I become a rare disease expert. It's crazy because I feel like over the 5 years, there were a few patients I've accumulated maybe early on, and it was very challenging to get a diagnosis. And like I had to go to Harrison's textbook of medicine, which I had time for because I have a DPC. And so in general, I feel like it was very interesting to see how things culminated into finding a mitochondrial disease expert and navigating that and just making connections through other patients' family who are genetics experts and like trying to bring the community together to help me help my patient. And that has been incredible because now with that scale at which I'm able to connect with the community. I have so many connections, like a massage therapist who's massage Anna Kournikova. Like, how do you get these people? You just have to be out there and reach out to the community, find these people. And so when I was able to connect to this mitochondrial disease expert, and then they told me the usual timeline for diagnosis of this takes about 10 years. And it's crazy that you've come to us in 2.5, 3 years. And for me, it was hard to even believe that 2.5 to 3 years is the timeline for diagnosis. But anyway, so that's been great success. Also, with my pickleball, I've been up and about everywhere playing pickleball. And we went to this one location, and the mayor of Escondido, not San Diego, but Escondido, which is a neighboring city, was there. And he had never heard about DPC. And I was able to share it with him. He's people with different political views, but having that common theme of I need care. He was not happy with his care. He was being sent around. And I'm like, you're the mayor. And it was interesting to see that he had never heard of DPC and he had never heard that this is something doctors do. They all know concierge, but there's this kind of personalized care. So that was very interesting. Also connected with more doctors since the DPC conference. So they've reached out for just figuring out how to get started. And that's been great to just share and give back. And then I've read a lot of books lately because I have the time. And there's this one book I have to share. It's called A Well-Lived Life by a 103-year-old doctor. And she's a white doctor who lived in Arizona for the longest time, but she was born in India. And like she actually spent years in India. She even saw Mahatma Gandhi. It's just incredible. I found that book and I shared it with everyone I love because I think she speaks about the true care DPC tries to give with connecting with another human being. And it used to be like that with doctors who are now 103. So it's great, and I highly recommend that book. But that's pretty much how I've been just so happy that I chose this path.
One of the things I wanted to go back to is Dr. Jake Mutch had mentioned this in the very first episode you guys did about Defiant, this idea of small batch practice. And I'm just wondering if you guys could all talk to us about how, even though you're 5+ years in, you've grown in some cases with multiple doctors, grown in terms of more community members, more physician community members reaching out to you. How do you guys still view the quality of care that you're able to deliver and how you actually do that, even though you might have more people in your DPC ecosystem locally?
I would say that small batch in my mind still means a little bit more proactive. We see people a little bit more often. We're talking about longevity forward stuff. I saw that Outlive book
Yes.
on Dr. DP's shelf. Like, we use some of this as a framework to help bridge that gap for patients, but we know that no matter what the physician curriculum or what they're going through patients, no matter what that looks like, ultimately, there's going to be stuff on the back. There's going to be obstacles, roadblocks that need to be paved in order to connect the dots. And so we realized in our area, certainly with our, I guess, some of our specialist conundrums, we've realized that, oh, no, part of what differentiates us is all of the wonderful work that our operations and clinical team does on the background to make up for the shortcomings of the healthcare system. And that's something we're extremely, I mean, it lights a fire under my butt like you wouldn't know. And because it's so disappointing, and to get it wrong is often to miss cancer or to delay diagnosis, and nothing pisses me off more. And so there's that part of it. And then trying to make a good experience for patients, for sure, doesn't require sheetrock and waterfalls, but we wanted to make sure that it was a good experience, and that there are some people who want kind of that physician care coordinator, but also a wellness professional too. And we're working out and devising what that looks like in the future. We're kind of seeing like the shape that that's taking. So that's how we think about splash care. Even though we're scaling the team, we want to keep a very small feel where everybody has people that they can trust and it doesn't feel anonymous.
And I think just building on what Deepti said earlier, about her finding the mitochondrial expert, it's like we are curating, hand picking specialists for people. We're not just sending them to whatever cardiologist is in our system and click a little box. It's like, no, who's the cardiologist that's a specialist on X, Y, and Z, and will also, their personality will match yours, so you'll have a therapeutic relationship, and I know you guys will have a good thing. And so I think that is one of the ways we keep it small batch, is like it is not cookie cutter, it is personalized. And I kind of know, not to knock on concierge, but I feel like insurance-based world is cookie cutter insurance-based world, and some concierge practices run it cookie cutter but expensive.
Yeah.
And everybody gets full body MRI, and everybody gets a gallery, and everybody gets X, Y, Z. I'm like, that's not personalized. You're just cookie cutter in the opposite direction. And what delineates us is that we are personalized for the patient in front of us, and we're not going to take so many patients per doctor that we lose sight of that. And that's really important to us.
Very similar to what Christina said. I'll give you an example. I had a 1-month-old that was just in for a well check, and I was doing his vitals, and I was like, huh, your heart rate's high. So I just left the monitor on, and I was like, okay, we'll feed him, we'll get him to calm down. Wasn't coming down. And it was like not SVT high, but and it just made me feel weird. Like enough, the doctor's spidey sense, I'm like, I don't like it. So picked up my phone, called the cardiologist, called Ped Cards, and I was like, I'm sitting here with this 1-month-old. We're staying in the 180s at rest. Room's dark. He's calm. I don't like it. What? Do you like it? I don't like it. He was like, yeah, send him down. I'll call the office. Give me the last name. We'll put a Holter on him, and then we'll give him a call in a couple days. And this is an insurance-based cardiologist, by the way. And just things like that you just can do things better. Maybe, I don't know if this is true in adults, but in peds, you can just call and consult with specialists. And so I had a kid with an elevated blood pressure on multiple well checks. And so I was called nephrology, and I was like, it's not like enough to be anything, but it's something. And he was like, yeah, get him. No one ever calls about elevated blood pressures. Yes. And ended up having some like kidney issues. And so exactly what you're saying, like you look at the patient in front of you, and like you are able to figure out, okay, the 1-month-old, they're getting ready to go on vacation. And it was like a big vacation thing. And I was like, and they were driving. So I was like, okay, that way you can, on your way home, put the Holter on. They can monitor. They got him set up, was able to go on vacation. I was texting and calling. And then I was like calling the cardiologist and reporting back. And you're able to do this. God, this really, what I imagined at 6 when I was like, I'm going to be a doctor and help people. Like, this is it. It is what I'm doing. And it's cool.
So cool.
It's like special treatment for everybody, right? Yes. It's like everybody gets
it's what I would want if it was
not for everybody.
Exactly.
Yeah.
Deepti, you're like biting at the chomp. So go in, just dive in.
Right. Well, I think this is so cool. Like this, over the years, connections with all these different specialists where you can just text them. I go visit bird conservatories with these doctors because I'm just like, you're cool people. Let's just go hang out. And then they ask me questions about internal medicine stuff when they have a patient who's coming in for a ear thing. The ENT doc was like, oh, she also has a brain tumor. Like, what do I do with this? And so it's just very interesting how we can actually help each other. It's not just one way. And I send gifts to these people whenever they help my patients once in a blue moon, random surprise. What do? I usually send those, all those chocolate dipped strawberries and stuff that they can, edible arrangements.
Oh, that's my go-to too for all our
Yes,
like
it's so
fitness
awesome.
studios. It's like kind of healthy, but kind of still a
Yes.
treat.
So I do that,
Oh,
and then it's just like all these doctors find it so convenient to communicate. It's not like they're hard or like they're trying to just please you and stuff. It feels very natural after a while. And so there's just like Lauren gave examples, I feel like there's one she was just struggling. She's a psychiatrist, child psychiatrist, who, by the way, a lot of doctors have become my patients. It's just, I think doctors are just so fed up, and they're the most burnt out profession. So she was ketamine for depression and like so many complicated things going on. And I just listened to her on the meet and greet. And I said, you need a rheumatologist. I texted Dr. Zach Fellows in Carlsbad. I texted him. I was like, I'm sending you a patient. I think it's rheum. And he is so good that he's not the kind of specialist who will say, oh, not my territory, go find somebody else. He was like, this seems hematologic. I'm like, great, okay, good. So he is one of those few doctors who's like really good internist too. And I think it's so hard to find, like Christina was saying, you want to cherry pick a doctor who actually cares, who's a specialist who cares, who doesn't want to say, oh, this is not mine, which is what I'm seeing a lot actually these days. Oh, this is not room, sorry, go find somebody else.
Right.
Not my problem. And I think those kind of specialists are the ones that have burned out within the healthcare system. And I would have become like one of them, just referring out all the time. And it's such a sad way to practice medicine because you did not become a doctor to just refer out. And I think all those examples you guys gave kind of really remind me of the same experience I'm having with my practice. It's like I just texted a neurologist because I saw like a 1 centimeter cyst in the right parietal hemisphere of one of my patients who has balance issues, but she also has POTS. So I'm like, well, the parietal hemisphere also has balance. So do I do anything about this? Because I don't want to freak out and send her to a neurosurgeon. And then they just having that conversation with the patient, she trusts me. There was no crying. You know what I mean? It's so much easier when you know your patients, they know you, and they know you would do anything to make sure they're kept safe. And I think that's why he just texted me and it's okay. It doesn't look like that would cause those symptoms. It seems like that might be parts, but keep an eye on it. And she didn't even have to see him. And this is a free consult. I think the community you give to gives you back. And that is such a big example in 5 years of practice. It's a really short time to have that.
Amazing. So I will put out a challenge here for all of the listeners, because as you guys are talking about people who we all can picture our specialists, our go-to people that we love talking with, I will say that this is one of the reasons why I had created the DPC directory. So the dpcdirectory.com. If you have a specialist who you love, please encourage them to create a profile. It's totally free to start. And what it enables is a place where these people can be visible to the rest of us and not based on what your Facebook algorithm says. So I definitely would say, to help empower us with pairing with the good people in our ecosystem or the good people who are helping our DPC patients, please encourage them to grab a profile. And then the second thing I will call out is I have created a patient-facing mapper of physician-led DPC practices. It's at caringdirectly.com. So if your practice is not on there and you are a physician-led clinic, especially the specialists, go on there, because as I'm recording patient stories, this is a whole separate stream than my DPC story. When those come out, there is a mapper that this is what I'm talking about on caringdirectly.com, where patients can go and find you as DPC doctors, but also specialists. Because if one of us doesn't necessarily know, hey, I don't necessarily know a mitochondrial specialist, but I found a mitochondrial specialist on this map and they're licensed in the state that that my patient is in, that's a way to help each other also. So I definitely would say the dpcdirectory.com and caringdirectly.com. Please add yourselves to those resources, because those were built as I realized people needed more resources from interviewing everybody on the podcast, and those are just out there live right now. So one of the things I want to turn to is we talked a lot about tools and technology and AI, and definitely over the past year, we've seen more and more come out. OpenEvidence is my go-to place now for, you can even create, everyone's, yes, you can. And if you have not, just pro tip, you can even say, please create a patient handout for sprained ankle, and it will literally do it for you. Because I used to have to put my OpenEvidence stuff into ChatGPT, and now that's not even a thing. But I would love if you guys could talk to us about how your electronic health records are functioning. We just had the results of the Battle of the EHRs come out, and it was very interesting to see the results from the community. But also, AI has, like I mentioned, just continued to blossom. So I'd love if you guys could share with us about tech at your practices.
This is definitely a fun one for me. This is my like nerd alert. And it's because I love like trying to optimize workflows and just looking back at like how we tried to handle all of this stuff when we were first starting the practice versus the technology that's available right now. I mean, it's just unbelievable. Now you've got the AI scribes, or we'll do like an AI dictation, upload it into the chart, have a note done in just a few seconds, which used to be quite a burdensome operation. But it's also wonderful because sometimes you can ask AI with our EMR like questions about the timeline from years ago, where it was like, hey, they've been having a lot of urinary tract infections. Can you like summarize the like all the urinary tract infections, what antibiotics were given, what things were isolated from the culture of sensitivities, and just and that makes it really easy. And then it's also wonderful because when you were trying to generate a referral or pull together a coherent timeline from, now we've had patients for some of them for 5 years. Sometimes you really have to go all the way back, and that can take so much time to save them time once they get to the specialist appointment. That requires a lot of back-end coordination to make sure that we have a compelling narrative for what happened, so they don't just get to the specialist office and the specialist office says, why you're here. Sometimes they don't read our notes anyways, but we stop referring to those specialists. But it's very nice because it's almost like having a really good intern or resident giving you a report on what has been going on with the patient, the text, the emails, all of that stuff, so that when you get there, you're fresh, you understand what's happening with the patient, and these people that you've known for so long, you're ready to move on with the next step. So it saves a ton of time from that perspective. We definitely use OpenEvidence. That has been extremely helpful as well, to whether it's every now and then for patient education, that kind of thing, but it's also nice to help summarize or think about a case in a different way. It's nice to get updates on what the newest stuff is, if there's anything we need to think about. And you can also like, for a lot of times there were like, if you're trying to, there are some like radiology guidelines that are just difficult and onerous to access. I'm like, I know what this, I know where we need to go. It's just going to take 40 clicks to get there. Being able to outline a patient condition and then say, this is what this complicated MRI finding showed. What is the typical workup? What other things should we think about? You're like, at what point do we do X, Y, or Z? What are the regular guidelines and when do those differentiate? Like all of those like complex questions that would have been like waiting on the horn to get a call back from a specialist or like doing an e-consult over a couple of days. A lot of that stuff has been replaced by having quick access to the data you actually need. And the fact that they're integrated with like medical journals and you can pull up those journals as well, instead of like random hallucinated articles from ChatGPT, that really helps. And so that has completely changed what we do, because we used to give like research to our clinical assistant, be like, hey, help us out, pull all of these articles. Like she was our ChatGPT. And so, and now it's, oh, we don't need to do that. And the more of that that's easy for the physician to actually do, that means that the team can focus on all of the other difficult nebulous care coordination stuff, and it helps keep our team kind of close-knit as opposed to having to completely destroy overhead with payroll for things that don't require that. They just require a better use of technology.
And I will make a point here that OpenEvidence is free. All you need is your NPI. And I will say that if you query one question, you can set the toggle button on. So OpenEvidence will prompt you to send you if there's an update on whatever question you looked up, as long as you have one question in the thread. But yes, keep going, guys, because this is also my jam.
I mean, I would just like the technology that allows me to see mitochondrial challenges in an airport while we're at it.
Your face is so straight. I was like, oh, was that? Oh, it literally took me a minute there. That was great. That was a good one.
In peds, our patients don't have the extensive health history. So it's, if you got a febrile UTI, you're seeing a nephrologist. So It's not as robust in the peds world. My EHR has the ability, and I've used it a couple times. It's quite judgy. If you can imagine, I tangent in my appointments. And there was one that I was like, I want to try this. Parents were doctors. And I was like, can I try this AI EHR assistant, whatever, scribe? And somehow me and the dad got talking about facial symmetry and like the concept of attractiveness and like equal symmetry and like what celebrities have really. I don't know how. I think it was about plagiocephaly, I think was our transition period. But the AI was said doctor and patient went off script or like something, and it was so judgy about that they talked about irrelevant topics. And it was like, hey, Brad Pitt's face is relevant here. Like,
irrelevant topic. That's so rude. I don't think
it was so judgy that I was like, how dare. And the problem is like in peds, we can't just do standard soap. Like our well checks aren't soaps. It's developmental milestones. It's MCHATs. It's ASQs. It's smoking. It's vitamin D. There is specific targets that like, not for metrics and insurance that I need, but like for healthcare that I need. And then AI just yet cannot go through and fill in my template. And I have to fill my template or I will go off talking about Brad Pitt's face and like never actually get back to the point of the visit. And so for me, it is not as helpful and it is mean. But I have used it. I use OpenEvidence constantly. I love OpenEvidence. Every time I use it, I'm like, sorry, planet, but like I'm a big fan. But for our EHR, again, it's like none of it's really specifically designed for pediatrics because we are not the money makers in any aspect of medicine. And so for EHRs, the only ever pediatric specific EHRs I've used are like so stupidly clunky and click heavy. And like, so I would rather have a very streamlined EHR that I can figure out pediatric workarounds than like a pediatric specific EHR. But like, again, outside of OpenEvidence, tech ain't. And maybe that's just my old ladiness. I bet it could be super helpful. I bet it could. I just refuse.
Can I just add on to that I don't think AI scribes are meant for DPC world because we
talk too much.
Hell no.
And so that's why Jake started dictating his note and then just having AI be the transcriptionist.
They were getting lost in the weeds.
It's getting lost in the weeds.
Because we're talking about, well, did you get the house? We're like,
exactly.
We know
it
them
cannot
so
function.
well.
It's like this is too much. And the better your prompt is, the better it gets at scribing it. But that takes so much time that I just haven't gone there. But I like that it has that add-on option at least.
It changes literally every age. So that just seems like way too much work.
Yeah, I know. I'm like, I'd rather just type out.
And I have it like now that I can
just send it in via Telegram. See?
Yeah. I have all my F2 like wildcards and I have my pre-filled common answers. So it's a note takes me 30 seconds. Unless something is wrong, in which case then I do get more detailed. And a lot of times I'm so focused because in DPC, I'm going to be like, okay, your 10 review systems. I can sit and I push the computer aside and we talk. And so then at the end, then I'm going to go through and summarize because maybe the information we talked about was relevant, maybe or maybe not. And so I myself with a quite extensively minuscule attention span is like, I can't even read through my own weeds of like my talking sometimes. And I just need the bullet points.
Definitely.
I do have an EMR which works with AI and for transcribing, and it does give me summaries, but I do have to go back in and edit it because, like you said, we talk about other stuff and it does a good job, but sometimes I think it confuses me to be the patient because patients ask me how I'm doing and I'm like, yeah, sure. I'll tell you everything about me. And they're like, oh, patient is reading this book. Patient is, oh,
yes.
What the heck?
I'm like, oh my God, my sciatica's flaring. And they're like, patient SA. I'm like, no, they're 2 months old.
See, exactly. And so I think it's useful to just make it easier where you don't have to type everything from scratch and then you can just go edit. But also on my phone front, it's anti-tech. I'm like, time limits for websites, time limits for browser, no social media on that. So you might have seen I'm a little quiet on social media. It's just I am living a simple life. I've become a mountain girl, even though I live in San Diego. There's mountains here, guys. And then there's lots more bird watching and all these other things. So I feel like technology is like you just got to use it the right way, use it exactly for what you need, and then say bye, because I'm needing artificial teardrops, guys, from screens. This is like after getting rid of social media and stuff, just because there's so much tele appointments, and you look at your phone because there's like a text from the patient and stuff like that. So there's always going to be stuff with technology that also can be negative, and I just feel the fine balance is, but I totally love the AI thing. I use it every single time with every patient. It's just not perfect, and so we just have to work around it. Yeah.
I love it. And I am the same way. Our AI scribe, just like Christina's mentioning, is literally dependent on how the level of detail is set and how your prompt is set. And so I do think that also this is a a recommendation for everybody. If you have good prompts, depending on your specialty, whatever, this is the type of stuff that we could share amongst each other so that it's not having to redo the wheel. But I totally hear you that getting the finesse of the prompt so that it works for what you need it to is definitely an ongoing challenge at our practice. So one of the things I think about, especially because you guys are now going into your sixth, I think about there's a lot more people in this movement, a lot more people interested in this movement, medical students, pre-meds, even residents. And I'm wondering if you guys could talk to us about common questions that you're seeing from them, especially fears about DPC, but also how you're answering them, peppering in your ability to balance your livelihoods with the practice of medicine because you chose DPC.
Ooh, I can do this one. I take students. And I talk about this probably every day with them. I will come back to you. Patient's calling.
I'll take this one too while she's on the call. So I will say that we have an influx of physicians who are now burnt out, right? So we're about 7 years from medical school. And so we are starting to hear from our formal classmates, co-residents who are like, I'm done. Please help me out. I need to get out. And it's like this second wave, right? Like I never really considered us early adopters, but in some ways we were. Obviously, we weren't the ones who doing it like fresh, but I would say we're still kind of part of that, the late early adopters or like late wave of the early adopters. And now we're seeing kind of it gets so mainstream and popular that people are like, oh, they're seeing the social proof. And now they're like more serious about considering it and trying to get out. And I relish in getting people out. I will talk to everybody I can to get them out. And so it's been so fun. And it's also how we have found our physicians, right? Like they are coming burnt out, pissed off. They want to practice medicine on their terms. And so now there is even more options to not be your own entrepreneur and trying to team up like our patients with other DPCs, or not our patients, our friends with other DPCs, and be like, oh, you need to talk to so-and-so in your region. I think I texted you, Maryal. I was like, oh, you need to talk to this person. And so trying to play matchmaker for DPCs now is kind of like my new pastime. And so that's that's been really fun. And I just feel like it's happening, guys. Like it is happening.
Yeah, and it's a lot of the, I guess I'm about to see actually two, I think one's a pre-med, one maybe a medical student tomorrow, but they are reaching out proactively. And those floodgates are starting to open because it's catching up not just in the people coming out of residency and getting burned out, but they're also starting to see it exactly where they should, which is before they hit year 3 of medical school. Because all these people who used to dream about being a primary care physician as a pre-med, or when they get into their first and second years, they see what life is like as a third year in a family medicine office. Let me tell you, friends, that ain't too pretty. And so now they're seeing a different competing narrative that, oh, no. Family medicine or primary care in general could be quite wonderful if done correctly. It just requires you to talk to people who have lived it. And so they're starting to reach out proactively. And I think that's where we're going to, what are we going to do about this primary care shortage or maldistribution or whatever? It's not about trying to shoehorn a whole bunch of people into suffering through 35 years of practice and just seeing 30 patients a day. No. It is restructuring the way that primary care is delivered to actually make it something that is sustainable and wonderful so that physicians medical students, people who have opted to go to dermatology or whatever because they were looking lifestyle wise, because they wanted to do primary care and then saw what that specialty was like and said, no thanks. Instead, they're re-looking at that and saying, you know what? I want to make a difference. Not to say that other specialties don't, but they have that dream of what they wanted to do and what they wanted medicine to be about and what those relationships wanted to look like. And they say, no, I don't have to give up on that. I can make that happen. I just need to talk to the right people. So it's very exciting to help people be a part of that and to help the movement grow. It's a wonderful thing. I love coming home after talking to a pre-med or a medical student about this stuff because you can see their eyes light up because they're seeing us light up too. It's great.
This is one of the reasons I'm so grateful for you guys all coming on to give your updates, because to me, especially when people are in pre-med or medical school or in residency, it's your guys' voices who I send, because I'm like, not only can you hear about how things were going before they started, but also now we're going into year 6, guys. So it's the proof is in the pudding. And also I think that it is a way for us to, whatever our feelings are about our professional societies, elevating DPC, celebrating different voices in DPC and not having the same people talk about the same topics over and over and over. My DPC story is very excited to be highlighting your guys' stories, the stories of everybody who comes on, because it's through diversity people find relatability. And I have heard that especially from residents saying, I didn't think I could because I'm the primary breadwinner. I didn't think I could because I'm a single parent. I didn't think I could because I live in rural state, whatever. And so I just wanted to say thank you also to you guys and everybody who's come on the podcast and who has yet to come on the podcast, because this is how we reclaim the narrative. And so I love that more people are reaching out to you.
A lot of my students, I take a lot of third years. And so I'm usually their first experience with direct primary care. First, a lot of them have never heard of it. And so there is like just even that little bit of exposure is great. And the most common question I get is they're like, you just have so much time. You have so much time. They're like, how is this happening? Or students come, I'm like, yeah, my kids are out of school, so you can come. They're gonna be here. You can hang out with them. If you hate kids, you don't have to. And there's a lot of, they get to see that. And so especially my students with kids, that that's everyone's worry. It's like, how do I be a doctor and a parent with kids? Obviously you don't have to have kids. So with a lot of these students, they're really worried, like, how can I have kids? How can I be present with my kids? And they get to see it. And I'll tell them, I'm like, yeah, I'm not going to be here Friday because we have lunch on the lawn. And so I'm going to these school events. I am going to the Halloween party. I'm going to on the pumpkin patch field trip. I'm doing these things. And that is okay, that you don't have to be a martyr in medicine, and
Yeah.
that it is fully possible to be a happy, successful, competent physician who actually has a life outside of medicine. And so I will tell, make sure you're exercising. I have them read like different books that I think are helpful in terms of not like textbooks, but like my favorite that I make them all read is Overkill by Paul Offit. I want you guys to learn, even if you don't want to do pediatrics, you want to do psychiatry, you want to do anesthesiology, you want to do whatever, want nothing to do with kids. You need to know how to not overdo medicine, regardless of the type of practice you're in. And it has been, I think, really good. They keep sending me students. I got a title that says I'm a professor. So I
Nice.
think it is going well for them too.
Yeah, so I think in general, the DPC conference was like one of my most biggest exposures this year of seeing doctors who are much more senior in terms of how long they've been practicing, and they burned out 3 times. What does 3 times mean? What is burn out 3 times? Like I burned out one time real bad, and that was bad. So I don't know how you burn out 3 times. So I guess The fear of having to start something by yourself and like the worry about how you'll make ends meet if you have a family and stuff like that is so profound. And the system systemically trains us to be very scared. Right from med school, they'd keep telling you, oh, you gotta join, you find a recruiter, and this is how you find a job, and this is how it's gonna be. This is these ICD-10 codes, this is, and the billing, and this is exactly how. And I still remember there's one doctor who I really hated. I don't want to use that word, but it was so, she made me see the worst of primary care during my residency. And she had all horrible things to write about me in my evaluations and stuff like that because my focus was on care and like the patients crying because they're suicidal and stuff. She wanted the CPD codes and ICD-10 codes written the right way. And I think it could really burden you if you're trying to get out of residency in flying colors, and here you are not impressing your professor who cares about that. And I think it makes you kind of think back and see just because they're a professor doesn't mean they're smart. Just doesn't. I mean, Lauren is a smart professor, but no, you are.
I
But
am, but not, there are real idiots in medicine.
yeah, exactly. And it's like dodos. They've been told by
Shout out
somebody
Vinay
else that this is the
Prasad.
way to do it. And here I am listening to the almanac of Naval Ravikant about how to get wealth and happiness. And he's my professor. Think about it. Like, you want mentors who've actually done well in life, not the ones who like want to write ICD-10 codes when they're like just upset all the time with everybody. And I think if you're writing bad reviews and not actually helping students, that's the worst kind of professor. Get out of that university. Just go find something else, because you are demotivating these spirits who are trying to like bring so much health and happiness in the world, and you're like extinguishing it by making them think about these stupid insurance codes.
Yeah.
And honestly, I have to just say this in this particular stage, insurance has gotten way out of hand, like way, way, way out of hand. I mean, I'm even thinking, do I retire already like this? Because it's like you have a mission, but if someone's like sucking the soul out of you every time, like literally yesterday's 5 appointments were all about me making calls that needs to be done. And I can see how it can be overwhelming for when you have way more patients, and that's why staff who are really good is beneficial. And I feel like it may make a difference, but I still won't do it. Right now, staff. But at the same time, it is very interesting. You pick up the phone, you speak with this person, and a stat MRI takes 2 to 3 business days to get a result. Like, what? When did that happen? In 2020, when I first started my practice, that was not the case. So imaging centers have gotten sloppy, pharmacies have gotten sloppy, insurance has gotten way, way worse. This whole prior auth nonsense is every 2 months, and they're like, oh, sorry, we already had it. Like, why did you waste my time? And I mean, you probably want to talk about this too, but I just wanted to say it right here because this year has been particularly very disturbing. I'm getting texts from pharmacists who are independent who are saying maybe because of the tariffs, their medicine supply is going to stop and they won't have all those cheaper alternative prices that we used to have for cash. And it's very disturbing to see that we were not in the best place to begin with. And now, even though there's more doctors who are burning out and coming out and trying to do this, it's just really shitty that I just wish I could heal people with my stethoscope, but it doesn't work that way. We need medicines, and we need the country and the world to just be way, way more proactive about truly caring about humans.
And
If
each
you
other.
figure that out, let me know how to get people to care about other people. So
Yeah. One thing that I do, first of all, I love your book recommendations, Deepti. And Naval Ravikant's the
Yes.
Almanac of Naval Ravikant is amazing. But the one thing that, especially for your solo practice, that I'm just kind of like riffing on that I'm starting to see in like the health tech world is like AI agents that can like make calls for you, sit on hold, and also sound like real human beings.
Oh, wow.
That is starting to get really, really good. And I'm just waiting for the right company to come along because that space is actively being developed. And so
Thank you.
when that happens and they can like report back to you on, hey, does the pharmacy have this or that, instead of you sitting on hold with a pharmacist. I actually know the jingles for most of these imaging
I
places.
know. It's so
Like,
good.
because it's I've been on them for so long, and not
That's
having to
amazing.
ask my staff or have to do it myself. And this can just be delegate like that. I am so looking forward to it. I think it's going to be a huge change. And I think that we're kind of in this AI romantic period where it was like penicillin 100 years ago. And now it's
Yeah.
like, how do we make AI work for us? It's very, very exciting. I just want to jump in there. Sorry, it was just a random scatterbrain comment.
No, that's very helpful to know because I was doing dishes and I had that thing on, and I need to turn the water down with someone saying, "You were in the queue," and it's, dude, I thought you were back. Like, what the heck?
Is it OpenEvidence that will do that'll listen to your prior auths and like immediately send you the like studies that they're talking about? I feel like I remembered hearing someone talk, I think it was OpenEvidence, that like you have it open like for prior auths and you have your phone on speaker and I think it will listen and send studies like proving the need of what you're looking for. And
Which is awesome. Yeah.
maybe
I was gonna say
I
it's
hope
gonna
I'm not
become
making this up, but
no, it's
I feel very confident that I've heard multiple people talk about this.
They can also generate letters to the same
yeah,
effect, but I haven't.
it's gonna be AI versus AI. It's gonna be the insurance
Like an
I
AI
artificial.
know exactly
versus
because
our
we already
AI
know Blue Cross
because
is using them
I
to
think
deny, and
there
so
was
they're
one of
just
the
going to
DPC
get.
docs that was saying that they got a denial and they're like, you approved this. What happened? They're like, ooh, that was actually AI's mistake. It should have never gotten approved. Did you guys see that story? And so I was like, oh my God, like it's gonna be like whose AI is better at this chess match of trying to deny and approve, right? And it's just gonna
Just being like, oh,
explode,
doctor
right?
said we need this to care for the patient in front of them. I mean,
Yep.
Right.
Yeah. And we're seeing, I mean, within the past 12 months, I mean, I was really racking my brain with this, trying to figure out our workflows because there is especially with the advent and use of GLP-1s for weight loss. Oh my goodness. Like it's all over the place. And like there's so many dangers to not getting it from a reputable source. And so
yes,
you really so I really have to explain to my patients, like, no, this is not something you want to get in a back alley. There's a reason we're doing it this way. But it's just so expensive, and it's getting a little bit better as they bring the price down. But if we're going through insurance, like a lot of patients naturally want to because they're paying these ridiculous premiums, it is very, very difficult to get covered, and it's just like really hard stops. So the amount of prior auth paperwork we've had to do in the past year compared to the last 5 years has just been astronomically.
like quadrupled.
Yeah. Oh, yeah, absolutely. Because we're dealing with one of the most common conditions, right? And so many people can clearly benefit from this. There's so many people that I was like trying to get blood pressure control and like the OSA route and the CPAP, da 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 da. And like somebody just sent me a picture of like their before and after from 10 months ago. And it's just like the before and afters are just fantastic. And so, and I don't mean to be like I guess an apostle of all this stuff, but like it really moves the needle for patients. And it's extremely frustrating that we're getting roadblocked left and right, where they will actually tell the patient one thing and the insurance company will tell us something different.
Yes.
They'll say, oh yeah, it just drives me nuts. They'll be like, oh, we don't see a plan exclusion here or whatever. Your doctor should just try another medication or try a different prior auth. And I'm like, you are giving what you just communicated to the patient was, oh, this door is locked. Why don't you your doctor try another key? The door is welded shut, and you were the one who closed it. Please stop wasting my time
Don't
and
do
theirs.
this.
And lying and saying your
And
doctor
They
lying.
do, they do
Yeah.
make it look, they do. I
Or
think they always want to make this, forever they've tried to create a hatred towards doctors because they feel like this is that one thing. Let us just get them fighting with each other and we win. And it's so easy with the DPC model to just go, they're gonna say this, okay? You're gonna get a letter saying I'm not doing my stuff, okay? Just be aware. And it makes such a huge difference because patients go, oh, there, I got that letter.
Yep. That is very
I
true.
had
Even
to.
for prescription refills, I'm like, hey, we get a bunch of refills that you never requested. They're like, you do?
Yes.
I'm like, yes. I was like,
Yes.
so stop like requesting it through the pharmacy. Just text me. Just text me that you need a
Yes,
refill, and
exactly.
I
Oh,
will
I
put
didn't
it
know
in
you had to do
because
it too.
it is
Wow.
like it is such a scam. They're like, I never asked for this. I'm like, well, they asked for a 90-day refill. I didn't. I'm like, yeah, they're just trying to get you refill that you didn't even ask for.
Right.
And so when I say that and then they get it, they're like, oh, okay. So you're right. At least we
I
can warn
always
them
check.
So we get
Yeah.
a little bit of street cred back that we're not crazy and we're not the ones doing it. Oh, Walgreens said that you denied my refill request. I'm like, I didn't get a goddamn thing. Please text me when you need a refill. And they're literally like, they denied it. I'm like, I got jack shit. Like, how dare they? Like, say you didn't hear from us, but don't dare you say that I denied it. Like, are you kidding me?
No, they do this.
Obviously, Maryal, this is a hot button. I'm getting red. I'm getting flushed.
You hit the tripwire.
Oh my God.
But I will say that it's not just a hot button for you. It's a hot button for all of us because it's literally a way to fake deny people care. And I will say
PBMs.
Oh my gosh. Well, I will say here though that to Lauren's point, OpenEvidence, this came out last year, so December of 24. They do have the OpenEvidence, again, a free resource. All you need is your NPI, has the administrative ability to write prior authorization letters, and it does use the evidence. This is from multiple journals like Jake was mentioning, but also citations and references. So absolutely, it is a thing to help with that frustration.
Yeah, and they sign a BAA too, like for PHI privacy.
You have to enroll.
Which is, it makes me feel so good when you're like talking about or trying to figure out a particular patient situation. I think they also have the ability to like, I haven't experimented with this, but something about uploading patient information from an avatar to use almost like as a reservoir for when you're asking about a specific patient's history. I haven't played with that, but I just kind of saw something like that. I was like, oh, I gotta like kind of look into that a little bit more. But it is, especially if somebody's EMR doesn't have native AI features and they're looking for a stopgap or something to take it further that's evidence informed, that, I mean, like it has really changed the practice and changed what I use as my default resource for getting medical.
For sure. I almost but I don't know if I use OpenEvidence or UpToDate more anymore.
Yeah.
Well, and with OpenEvidence being free, I mean, it was a no-brainer for
as a professor, I get UpToDate through my school.
Yeah.
I love it. So talking about hot button topics, as we've been alluding to this entire conversation and on multiple conversations on my DPC story, direct primary care is where patients go to for relationship-based medicine. They go to establish care with a physician who they can trust. And in this day and age, misinformation, even where to find guidelines for professional use is getting challenging. I won't even go to the CDC anymore right now, unless I have to download VIS sheets for vaccine clinics.
Use immunize.org.
So this is exactly what I want to talk about. I would love if you guys could talk to us about challenges that you've seen in your own populations and your own communities and how you've been able to help your patients ride the wave of whatever the heck is happening in this country because you are DPC doctors. I mean, just to call out, Dr. Hughes just happened to be on a call with Senator Elizabeth Warren. That's cool.
What I do want to point out, I was in full-blown outfit mullet. I had on a blazer and biker shorts. So it was an outfit mullet. I was sitting down and I don't know how that happened either. Wow. We are all as confused as you.
Yeah.
I would say it's intentional and it's strategic, right? Because we are literally standing up, just like Christina said, so that everybody can access this quality of care. And we're delivering it in a way that is affordable, accessible, and is expandable when more people are doing this movement. And this is where I would love to see how you guys are truly navigating the current changes and whatever happens with the loss of healthcare access that is going to be tremendous. I mean, just to give you a perspective from our rural community, 4,000 people in our community are getting CalFresh benefits, so fresh food benefits. 1,500 of those will lose their benefits by March. And then if you throw in work restriction, and the number of
already
people
in place.
Yeah. So I will say that this is where we as DPC doctors we're living in this place where we can say, yes, those things are happening, but how can we make a difference? Because I definitely have my own answers as to how we're doing things here in Calaveras County, but I'd love to hear what you guys are doing.
I think one of the things that we did pretty early on was take a stance on measles.
Yeah. That was a big
we lose one family from that email, but we decided, so one, in adult world, very different. There's a subset of people who may have only received one vaccine and Dr.
Yeah, they
Hughes, you can
missed
stop me
they
if I'm
missed that
incorrect.
window of the 2-dose
Right.
recommendation. Yeah.
And so we have a huge population of that. And a lot of them are now grandparents or have or maybe are around small children or daycare workers or working in the schools. And they don't know that they're not immune. And obviously T cell, humoral, blah, blah, blah. But still, they want to be sure we get it as med students. They want their titers. And so we're like, hey, we did this entire handout. Hours of research trying to make it digestible. Jake's awesome skills, making it beautiful. And we have this timeline and we're basically an algorithm for all our patients. I was like, if you're born here, you're good. If you're born here, you're questionable. If you're born here, you probably need titers. And did that whole timeline. And then it linked to a Google Doc and we did a measles titer clinic because the recommendations did not make sense for DPC. They're like, oh, just give people boosters. The titers are too expensive. I'm like, they're $20 for MMR. They're $9 for just measles. So this is very different. And in adult world, nobody has their childhood immunizations. They're like, I got whatever the doctor told me to get, but okay, well then that's what made me think, oh my God, I need to know the history of this. And so we had to do a deep historical dive to understand what there was because nobody has their records. So it was actually more economical for the healthcare system for us to do a titer clinic for next to nothing than to send them for a booster that's really expensive that the insurance may or may not pay for. We saw very similar as 10% or non-responders to one. We had a very similar 10%. And some of them were school teachers. Some of them were taking care of grandchildren and they got their boosters and they're like, oh my God, thank you so much for doing this. Thank you for just even talking to us about this. We're scared. We're hearing things in the news. And I did this so much earlier than I feel like anybody else too, because everybody in town was like, huh? And I'm like, I got my kid's second MMR booster in October. I was like, I'm hearing inklings. I want it now.
Yeah.
And I'm like, I'm not waiting. There's zero reason to wait. And so we did this, in the spring, and we had a great turnout. People were so appreciative. And it was just such a great way to be like, let's focus on what we can do with our community for our people and make intelligent decisions based on the information we have and just drown out all the noise and be like, we're going to take charge and do what we need to do for you guys.
Yeah. And it really helps to be able, like sometimes, I don't know, this is just my own thing, in trying to give people the full story of something, sometimes it dilutes the message a little bit where, should I get a vaccine? Well, there are like 3 schools of thought and and that, and all the patient hears.
Because that's the problem with science communication. It's nuance.
Yes, right. Exactly.
Stand for nuance.
And what they hear is that we have equivocated, so it must not be that important. And so being able to distill to as many patients as we have that, no, measles is the most infectious disease on the planet and it preferentially kills children. Like being able to say, this is where we stand. These are the diagrams. These are all the diseases that you're worried about over here. And this is measles, way on the right side of the infectivity curve. Our patients often need to be convinced and want that information. But what I've realized is they want a doctor who takes a stand. And I mean, listen to the early episodes. Oh, like I've felt and acted in a different way in the attempt to try to be as professional and that kind of thing as possible. But what I'm realizing 5 years in with the comfort of a full panel, being like, no,
this is who I am. This is what I stand for.
This is what you stand for. And a lot more people, it is so much easier when you just lean into that and say, this is what's going to happen and this is what's not going to happen. This is how I'm going to be treated in my clinic and this is not how I'm going to be treated in my clinic. And if you have a problem with that, the door is that way. And it really clarifies things because all of a sudden you get to solve the problems that actually matter. Right. And you just remove all the stuff that's a distraction. I love it. And that's why I love my practice.
There's so many things I'm scared of. And I think, so for example, like one of the things I've been talking with my families about who have Medicaid, who have kids with complexity, I'm like, we're ordering equipment now while we have Medicaid. So that stander you need, that gait trainer you need, that bath seat you need, that adaptive wheelchair you need, all that stuff, we're going to start that battle now while we still have Medicaid. And so that is like one of the ways, which I don't know, just kind of an aside, because I do think this is something that we need to talk about as DPC docs. The big beautiful bill will benefit DPC while it shits on a third of Americans. And that feels very icky. And so that is not something that I am addressing at all, is like the benefit of direct primary care from the big beautiful bill, because I don't believe that we as a community, as a DPC community, are wanting to do this on the back by stepping on the backs of Americans and like taking away their healthcare. I don't want to force people into DPC. I want them to choose DPC, not because there's not an alternative, but because they realize, oh, okay, this will work. And so I kind of want to put that out there. Again, like taking the stance, like I am always going to do the benefit of everyone, not the benefit of me, which is again, going back to what Deepti said, getting people to care about other people is an inherently American issue. But so like that is one of the ways that we are addressing it is, okay, for our Medicaid kids, what can we do now that is going to be expensive and is going to be one of the first things cut, which I already have had issues trying to get what insurance companies call luxury items for parents because their 3-year-old needs a wheelchair and they're calling that a luxury item or a bath seat. And so I'm using OpenEvidence to write. I'm like, no, here's how he can drown. And like that sort of thing. We're already looking at that. So that is one area that we are preparing our patients, and kind of going back to what Jake and Christina were talking about, which is just like that we can be proactive. We are able to help with just navigating like how you were saying, like a Titer is $9. Like we're having families utilize that and like I am talking about like ahead of open enrollment. My monthly newsletter was like, hey, here's, if you are a self-employed person, here is some other options. If your premiums are too expensive, here are other options. And so just using that as a way to communicate directly to our people and get the information to them as accurately as possible.
So I think I try to keep a pulse on what's going on in the community around me, because there's pharmacists, there's in general the key people that play a huge role in my patients' lives. They like deliver medicines for much cheaper than the regular system. I think over time, this is how it's been. Even in India, there was polio, and we did oral polio vaccines. We went house to house and put drops in kids' mouths. And I think talking about all those kind of things with my patients over the years has built that trust. And there's this trust and confidence that there is DPC that will remain, like no matter what my insurance and like employer situation is going to be. I've had friends who quit the VA, and similarly patients as well, who had lost their jobs, and then they were having really good insurance through the VA, and then now they had me as a DPC doctor, but then now it's like they were scared. They were scared about being without health insurance. So I had to kind of like help them navigate. You can buy, and then you can purchase it separately, and you can have your private practice, and they're doing really well there. They're not doctors, but they're in healthcare and doing extremely well, thanks to that trust and faith they had, where they could comfortably leave that job and transition. So DPC made just this relationship made an impact to the point that they could make such a big career decision and actually see way more growth in their wealth compared to how it was with the VA. And I think all I can say is you just got to stand by, just like you guys said, just got to stand up for what you believe in and what you know science tells you for a fact, and there's no two ways about it. And then no matter what the political situation and whatever else going on, if we just stand really strong on evidence-based science, and then have that compassion while, like Jake said, being very clear about how you would practice medicine and never put anyone in danger, because of how there's a few nuanced things out there about the topic, which has been very well studied by like molecular biologists and like all these like vaccine experts. And it's really, really hard to, because I know someone who was a professor, who was like a dean of a medical school, molecular biology professor, won like the top award when he retired. And I can see the pain in his face, because when he's retiring, he expected things to be way more scientific and advanced, and unfortunately it's like a cliff. And he's very hopeful that the people taking over next will grow this, but it's hard. It's a hard time.
I definitely appreciate you guys sharing another update, year 5 in review, and I'm so excited to hear year 6. Join us over on our Substack. We're going to be talking about the challenges that these practices have been experiencing in the last year, and I hope that this is very helpful for those people out there who are considering DPC or who are wanting another set of stories as to what they have looking in the future for their practices. So thank you guys so much. Thank you for listening to another episode of My DPC Story. If you enjoyed it, please leave a 5-star review on your favorite podcast platform. It helps others find the show. Have a question about direct primary care? Leave me a voicemail. You might hear it answered in a future episode. Follow us on socials at the handle @MyDPCStory and join DPC Didactics, our monthly deep dive into your questions and challenges. Links are at mydpcstory.com. For exclusive content you won't hear anywhere else, join our Patreon. Find the link in the show notes or search for My DPC Story on patreon.com. For DPC News on the daily, check out dpcnews.com. Until next week, this is Maryal Concepcion.